Good afternoon, everyone. This is Feng Tran with the Community Technical Assistance Center, and I'd like to welcome you to today's webinar, Identifying and Treating Self-Harming Behaviors Among Youth Using Technology and Social Media, presented by Dr. Nicholas Westers, who's a clinical psychologist at Children's Health and an associate professor of psychiatry at the UT Southwestern Medical Center. So please note that upon joining this webinar, you've been placed on mute to avoid any background noises that may distract others from listening to the presentation. And if you come across any technical issues during today's event, please chat to the host, Connor, who will be able to assist you. And you'll also have the opportunity to submit questions for the Q&A portion of today's presentation by utilizing the chat feature at the bottom of your screen. If you don't see it, look at the bottom, click chat, and then it should pop up on the right side of your screen. And so in order to ensure that we're able to answer as many questions as possible, please submit your questions anytime during the webinar to the chat box, and we will collect them and ask them to Dr. Westers at the end. And lastly, please fill out the feedback survey that will appear on your screen or get chatted to you at the end. So you can let us know if you have any feedback or suggestions for topics you'd like to see in the future. So we're very excited today to have with us Dr. Nicholas Westers. Thanks again for joining us, and I'll now pass it along to Dr. Westers to get us started.
Thank you, and thank you for having me. I'm coming from Dallas, Texas here. I did my graduate training on the East Coast in Virginia, so I know most people attending today are over there on the East Coast in New York, and I think there's some people from other locations as well. But I'm really happy to talk about self-harm in general, and it's a topic that I've had interest in since graduate school. And starting with a story, I don't know how many of you remember when MySpace first came out. I actually was in graduate school, and when MySpace had come out, I had this brilliant idea, what I thought was brilliant, or not brilliant, just curiosity of checking on a patient of mine or client of mine at the time who was 18 years old, and looking at her MySpace page, I saw next to her profile image, you remember you could use quotes, you could put quotations, and it was something related to suicide. And in that moment, I didn't know what I needed to do, and if I needed to reach out to her or call her, have another session that week, because she was also chronically experiencing suicidal thoughts and engaging in non-suicidal self-injury. And I learned a valuable lesson, and we'll get back to the story later in this presentation, but some of you might have similar stories. So as an overview of today, I'd like to start with a brief review of research examining the associations between social media use among youth and self-harm, including risk and protective factors. And we'll then focus on discussing how social media and technology may be used to screen for suicide and non-suicidal self-injury, followed by a discussion of risk assessment tools for suicide and non-suicidal self-injury that you can implement in practice. Some of you are already implementing. And we'll end with a review of some what I consider promising brief technology-based interventions for youth who engage in self-injury or who are at risk for suicide. So by the end of today, it's my hope that you'll be able to explain the relationship between screen time and social media with suicidal thoughts and behaviors, become familiar with general screening measures for self-harm if you're not already familiar, and then discuss some newer technology-based interventions for youth who self-harm, particularly single session interventions, or some might call SSIs. But I want to first make sure we're on the same page regarding terminology. So self-harm is an umbrella category and an umbrella term under which suicide, non-suicidal self-injury, substance misuse, disordered eating, and other self-harming behaviors fall. But today I'm focusing more on suicide and non-suicidal self-injury, or NSSI, as forms of self-harm. So when I say self-harm, I'm referencing both suicidal and non-suicidal thoughts and behaviors. And then when I'm not saying self-harm, I'll be specific on which one I mean. So many of you are probably already aware of the research examining the relationship between youth mental health and media and technology use, but I want to highlight a number of new studies, or a few new studies that have come out this year or last year, but most of you are probably already familiar with this seminal study that came out toward the end of 2017, early 2018, that found that adolescents, especially girls who spent more time on new media, and by new media, that means social media and electronic devices like smartphones, were more likely to report mental health issues. And adolescents who spent more time on non-screen activities, like in-person social connections and interactions, sports, exercise, homework, print media, and attending religious services, were less likely. More specifically, risk became elevated after 2 hours or more a day of electronic device use, when 33% of adolescents had at least one suicide-related outcome, compared to 29% of those using electronic devices 1 hour a day. Among those who used electronic devices 5 or more hours a day, 48% had at least one suicide-related outcome. And the researchers concluded that adolescents using devices 5 or more hours a day versus 1 hour were 66% more likely to have at least one suicide-related outcome. Now, the suicide-related outcome used 4 questions from the CDC YRBS data that comes out every 2 years. And it includes past year suicide ideation, past year suicide plan, past year suicide attempt, or simply feeling so sad or hopeless almost every day for 2 weeks or more in a row that they stopped doing some usual activities. So I'd be more interested in the results if they omitted this last suicide-related outcome, as that sadness and hopelessness is probably a better reflection of depression than it is suicide. And so I wonder if that would hit, including this item on sadness and hopelessness as a depressive outcome as opposed to a suicide-related outcome, could actually convolute the results. And then, of course, that would lead to a less provocative headline or less provocative title that you see here. So a lot of you are familiar with Jean Twenge's research in her work, and she's a great researcher, but I think there tends to be this sense of pessimism when I read her studies when it comes to looking at how she perceives youth and social media. More recently, rather than simply look at screen time in general, let me get to these here. Oops, there we go. Okay. Twenge looked at different types of screen time, asking adolescents in the United Kingdom, so over in the UK, about hours per day spent on social media, the internet, gaming, and television. And she found that hours spent on social media and internet use were more strongly associated with self-harm behaviors, depressive symptoms, low life satisfaction, and low self-esteem than hours spent on electronic gaming and TV watching. So girls generally demonstrated stronger associations between screen media time and mental health indicators than boys. And they define self-harm behaviors with a simple yes or no question, asking them, in the past year, have you hurt yourself on purpose in any way? So we don't know, does that mean it's non-suicidal or if it's suicidal, hence the term self-harm. And then using the same question, she and colleagues published a diary study this summer, July, and found that specifically girls who spent 2 or more hours a day compared to less than 2 hours a day on social media specifically, were more likely to report having self-harm, but they didn't find these results for boys. And then there's the criticism that a lot of the focus is more cross-sectional research instead of longitudinal, so not being able to determine causality. And then this past year, another study that came out that looked at both a cross-sectional and longitudinal design found that for girls, it was entertainment apps that increased risk. More screen time with entertainment apps increased risk for suicide, and boys, it was a combination of not just playing video games, but playing video games and being bullied while playing video games was a risk factor. And then they found a couple of unique results in the cross-sectional study for boys, that it was those who spent more time on reading apps, and then those who spent more time on education apps, while also using social media negatively, were at increased risk of suicide or attempting suicide. And they speculated, I mean, if you look at the reading apps, Reddit, the news, a lot of that's very negative. And then when it comes to education apps, it's a little bit surprising, unless the researchers here suggested that perhaps they're comparing themselves. It's the social comparison piece on these education apps that is leading to maybe the suicide risk, where they're not performing as well as maybe other peers or other people using those apps. But longitudinally, causality is a little bit, we can determine a little bit better. They did not find any longitudinal results specific to screen time in boys and the increasing risk for suicide. For girls, however, similar to Twenge and her colleagues, they found that using social media early in high levels, meaning 2 or more hours a day, that increased over time over the following 10 years, over the following decade, was associated with increased risk for suicide. And then same thing with television, early and high levels of television, and then video games, which was interesting. But they didn't necessarily differentiate between video games on social media apps versus actually just playing video games using a console. So that's a lot of that's screen time. But what about specific risk factors? And here's a new study that came out that looked at 8 potential online risk factors, including cyberbullying, depression, drug-related content, hate speech, low severity, self-harm, profanity, which the researchers suggest could be a proxy for challenges in emotion regulation or a general proxy for life stressors in general that's not captured in the other variables here, sexual content and violence. You can see on the right, this is a screenshot of the figure. They found that cyberbullying was most common among those who had reported attempting suicide compared to the controls who did not. And they used, this was a study that used a tool that is free access that a lot of schools apparently are using called BARC. Some of you might be familiar with it. And whenever they would use a school related device, whether it's a Chromebook or whatever, or a computer, if they're on a school related device, if they were to engage in cyberbullying or be bullied, or use profanity, when they were engaging maybe in their social media accounts or any online activities, then that would, that they looked at that compared to any comments related to suicide. If there's a comment or using algorithms that screened and found suicide, then the school was notified immediately. And so this is where the researchers looked at, well, what were those risk factors that were linked to those suicide-related outcomes, or the search terms, or using those that terminology, and found that all but really hate speech was not associated or any differential relationship compared to those who did not use suicide-related terminology. And low severity self-harm, this is a little confusing in this study. I think they looked at more that as a third, like a third person variable. So not them necessarily using or talking about low severity self-harm, but accessing others and reading their accounts of self-harm. And so here we have the total volume of online activities was associated with these alerts that the school would get that was let them know that there was a severe suicide or self-harm act or concern. And then profanity, depression, and sexual content were the risk factors most associated with these severe suicide self-harm alerts. And they wanted to model this after the ACEs study, the Adverse Childhood Experiences studies that a lot of you are probably already familiar with, where cumulative stressors relate to adverse outcomes, like cumulative stressors in childhood relate to adverse outcomes later in life. And so they looked at the total number of risk factors present, so 0 through 8, but they just kind of capped it at 5 or more. So those 8 online risk factors that we mentioned, and found that as the number of risk factors were present, each of those 8 factors, then risk for suicide and self-harm alerts also increased significantly, and especially when it came to 5 or more of these risk factors. So specifically, there's an increased risk of severe suicide / self-harm alerts with each additional type of risk factor. So let's talk about social media specifically. Here's a study that just came out where found that attempting to predict suicidal thoughts within the past month using social networking data of 52 adolescents on Instagram with a history of suicidal thoughts, they used machine learning models here. So this ensemble machine learning models, which I'm not as familiar with, as beyond my expertise, but the researchers found that they achieved a 76.9% sensitivity and 65.4% specificity, meaning they were actually able to correctly classify individuals who were acutely suicidal as being acutely suicidal 76.9% of the time, and correctly identify those who were not 65.4% of the time. And these were the top 5 most influential features in predicting suicidal thoughts in these youth, these adolescents using Instagram. Actually, the number of accounts that they followed, overall engagement. So was the adolescent, whenever they posted more pictures, likes, and had more comments and engaged more with the content, was actually associated with suicide risk. And then negative emotion words. They interviewed these adolescents through the Instagram Messenger and asked them questions, and then they actually analyzed the interviews and found that these adolescents were using more negative, I put that in quotation marks because I don't like to label emotions as negative or positive, but in the study they did. So using words like hatred and sadness, they were more likely than those who did not use that to actually report suicidal thoughts. And then if they had I think a higher number of followers was also associated. But the average number of likes per picture within the last month was a smaller number. If that was actually a risk factor, and they suspect that's some of the content that they post might be taboo. And if it's about suicidal thoughts or suicidal behaviors, other people are less likely to like those because they don't necessarily want to reinforce it. And so lower average number of likes per picture within the past month was associated, actually contributed to the effectiveness of this model. And then last summer, or I guess 2 summers ago, a neat paper came out through American Psychologist. For those of you that are members of the American Psychological Association, you probably had seen this. And looking at Twitter, these 2 authors at Auburn machine coded 64 million Twitter posts from 17 million users to examine suicide-related verbalizations, like comments, or SRVs. You can see that listed here as an acronym, and found that these kinds of posts were assortative, meaning they were linked through 6 degrees of separation, even when controlling for mood. So that means that if a user posted a suicide-related verbalization, then their friends and their friends' friends and their friends' friends' friends, et cetera, up to 6 degrees, were significantly more likely than chance to also post suicide-related verbalizations, even though they never met. And so in practical terms, then these authors actually suggest that if an adolescent attempts or dies, unfortunately, by suicide, and then schools are trying, for those of you that work in schools, are trying to screen students for suicide risk, and they just don't have the resources, which most schools probably don't, at least not here in Texas, probably mainly because of time or financial constraints. Rather than randomly screen students, the school psychologist would actually identify the student's closest friends, and then the one who attempted suicide or died by suicide. They would find their closest friends and then screen them for suicidal thoughts and behaviors. And then any positive screens, then they would identify those students' closest friends and then screen them, and so on, until there are no more positive screens, or there's sufficient time to screen students at random until one screen's positive, and the snowball procedure can then be used again until the time or resources are exhausted. So using this assortative technique would be significantly more likely to identify positive screens than with simply randomly selecting students to screen for suicide. So let's talk a little bit about social media and technology and using it to screen for suicide. I started this presentation by talking about what I would call a lapse of clinical judgment. I mean, I was a graduate student, MySpace, just curious, and knowing that this 18-year-old that I was working with had a history of suicidal thoughts and behaviors and non-suicidal self-injury. That was actually before we even called it non-suicidal self-injury or NSSI. And so thinking about my this 18-year-old that I saw, we did a suicide contract, which we created a suicide contract, which we know nowadays we don't do that. We do safety planning. But back then people talked about, contracting for safety. Well, for her, we did a suicide contract, which there are many issues there because first of all, it's not, those things don't hold up in court if something were to happen. And usually with a contract, those would have an end date. So it'd be a beginning date and an end date. So we'd meet on Mondays, let's say, I don't know, every week on a Monday. So the next one would be on Monday. So I wanted to be able to get through the week. And again, remember, this is like one of my first clients ever as a graduate student. And so we put the end date the next week. And then she wanted to add to there, she wanted to stop cutting or stop engaging in non-suicidal self-injury. So she added that to the contract and then signed and dated it. Well, a week went by and then she no-showed to our appointment, meaning, and then so the contract expired. And I became worried, well, knowing she's chronically suicidal, that's when I actually looked up on MySpace and saw that she talked about having suicidal thoughts or wanting to end it all and making one of those passive comments about not mattering to the world. And I called her, left voicemails, and it was 2-3 weeks later that she called and then scheduled and came in and told me that she had indeed attempted suicide and that she had with alcohol and Xanax and woke up a day or two later or something. And for her, she broke the contract in her mind because she cut, and that nullified the entire contract. And so she's like, well, that doesn't, so we don't use safety contracts for many reasons, but safety planning is what's most important. But from that day, I've never checked on I've never looked up on any clients or patients' social media accounts because that's just, I've learned from that. I don't know how many of you have learned or how many of you have checked on it. And there also talks about ethical considerations that we need to have because back then there was everything was new. We didn't really know, but that was just a life lesson that I had learned and have not done it since. But now we have a better understanding. We have better guidelines and ethical recommendations for using our own social media accounts as professionals and personal individuals, and then also how we might use or not use those of our clients or patients. However, there's a report of a young man who, this number 3 here, a young man in the emergency department, he was altered, disoriented, and not providing a clear history to his emergency department providers. Physicians successfully identified him by his MySpace page and learned from his postings that he was experiencing severe psychosocial stress. This prompted a psychiatric evaluation, and it was subsequently determined that his altered mental status and disorientation had been the result of an intentional overdose of muscle relaxants. Another case documented the case of a medical student in his 20s with a history of depression and suicide attempts. And when he failed to match into a residency program, he attempted suicide by intentional medication overdose. But before doing so, he posted a goodbye message on his Facebook page, and an alarmed friend notified the police, and the evaluating medical team sought and was granted permission to view his Facebook page, and the information there helped them pinpoint the exact time that he ingested the medication and then aided them in their ability to treat him successfully. And then another example is when an adolescent male using Snapchat broadcasted his own suicide attempt. His ex-girlfriend captured an image of a bottle of acetaminophen that he sent her, and she then shared it with his parents. And using that picture, the treating physician was able to determine both the time and dosage of the ingestion. So he underwent, as a result, a speedy recovery, in large part because of the information that was gleaned from his social media accounts. And another story, a 13-year-old girl posted pictures with suicidal themes to her social media account, and her parents shared the images with the evaluating physician to assist in obtaining a psychiatric evaluation and care. But then questions came up because her account had been set to private. So although she was a minor and her mother brought the pictures to the physician's attention, the physician didn't directly seek assent from her to view the private social media content, which thus raised questions as to whether or not this would be a violation of privacy. So just kind of thinking about how social media can be helpful in cases of suicide outcomes or suicide attempts, and does that merit breaking that possible privacy to save that person's life? I think there's some ethical questions there. For me, I just don't check social media anymore after my experience with MySpace. Well, earlier I mentioned Bark. It's that free online safety tool. So if we're talking about screening still for self-harm, it's apparently used in more than 2,600 school districts in the US. I'm not endorsing this in any way, but just sharing this as a resource as it monitors and sends the school alerts and the parents alerts for issues detected on the school provided computers, the tablets, and cloud-based accounts for content that actually threatening to the health and well-being of students, such as messages about self-harm, suicidal ideation, online predators, bullying, or threats of violence. And so this is an example of some of the text that it will detect using its algorithm, and referencing the study that I mentioned earlier of the 8 different online risk factors. The example text of the severe suicide self-harm would be I'm not sure you get this, but I'm going to commit suicide today. I love you. Thank you for trying to help me, but I can't hang on anymore. That'll send the school alert if they use a school-related device. If it's on their own personal device, then this doesn't pick up on that, of course. So these are just some examples. Now, thinking about, I guess, non-suicidal self-injury, back in 2007, some colleagues of mine, actually that was when I was in grad school, Janice Whitlock, Wendy Later, and Karen Contario, published a paper about the internet and self-injury and what psychotherapists should know. And there are a lot of great questions in that article. It's 2007, you can find it and use that as an example of some questions you might ask a client of yours, particularly an adolescent client who self-injures, and about their online activity related to self-injury. A more recent paper published in 2012 by colleagues, Stephen Lewis, in Child and Adolescent Psychiatry and Mental Health. By the way, that 2012 issue of Child and Adolescent Psychiatry and Mental Health is open access, and it's all articles on non-suicidal self-injury, so you can find that online. But here are some questions that they recommend as you screen for non-suicidal self-injury. Well, you can actually ask about the website being professionally or peer-driven, how's it moderated, but more the social networking aspects is what I'll be wanting to ask my own clients and patients. What social networking websites are you affiliated with? Most of the kids that I see now are mainly on Instagram and Snapchat and Discord. I think Twitter is not as common among young people as much. Same thing like Tumblr, not as much. Some of the kids that love journaling, or they might go on Tumblr, and then Facebook, not as they're not using as much. But for the most part, it's Instagram and Discord and Snapchat. But asking them, do you have friendships, connections with people online about self-injury, related to self-injury? If yes, asking about the nature of the relationship, and if they're a member of any group related to non-suicidal self-injury. If yes, what are the themes that that you talk about? Because if we're talking about risk factors and protective factors, social media and the internet and online, like they're not necessarily always a risk factor. A lot of young people and adults go online to seek support. They may have not told anyone about their self-injury. Even you as their therapist, they may not have told you, but they may be online talking about these with other people, or might come out and disclose their self-injury online to test the waters to see how people are going to respond, because they may have seen other people respond or heard about other people responding and getting really negative reactions, bad reactions from from people to whom they've disclosed. And so they may want to test the waters before they tell their parents, before they tell you as a therapist. But it's always interesting to hear what our clients are doing online. What kind of social media are they using, and how are they using it? Because more than anything, it's not like we talked about screen time. It's not so much how much screen, like how much someone is on their screen is it is what they're doing on their screen. It's more of what is a risk, like who is most at risk and why. It's not everyone, but what about that person places them at greater risk for a suicide related outcome or self-harm related outcome. And so a lot of them are going online for community and finding connections. So it's not all bad, but sometimes they get triggered. Going on Instagram, they may be triggered by an image that they see. But then again, sometimes they go on Instagram to post a picture of themselves with some of their scars. And sometimes like an issue that they have is Instagram like will censor them. And then they have this whole hashtag movement saying, don't censor my skin. You know, like this is who I am. I don't want to trigger anyone else, but you got to let me post a picture of myself, Instagram. You know, this is these aren't open wounds. So I think there are ethical considerations there as well. But and then asking about websites that they visit. Did they create videos or photos? Are they posting images of themselves or their wounds or scars online related to their self-injury, and what are they seeking to achieve as a result? Some want to, seek support, and others want to, again, test the waters. Like, am I going to be rejected for what my skin looks like right now? So you can find this article on online. It's open access again, and we're going to share this PowerPoint after the presentation, so you can go back and find all these resources on your own. So we're talking about screening, talking about risk assessment tools for self-harm. I'm not going to spend much time here because most of you are already aware of what resources are out there. More specifically, the Columbia Suicide Severity Rating Scale, the CSSRS. We use that a lot here in our hospital, and it's and we also use it a lot with research. A lot of you are familiar with safety, suicide assessment, the 5-step evaluation and triage. These are all open access. You can find them online. These are just screenshots that I took of the measures. So identifying risk factors, protective factors, we just talked about some of those. And then asking about suicide, determining risk level and intervention, and then documentation. Another one that's a little bit shorter is the ask suicide screening questions. And actually, I don't have this as a resource, but I wrote a paper in the journal Clinical Child Psychology and Psychiatry, CCPP, on managing risk and self-harm in pediatric medical settings. And so for those of you that work in medical settings, you might be interested in that. But we do use this measure here at our hospital in Dallas, and asking our patients about suicide by just a few items here. And then if the answer is yes to any of those 4 questions, then you ask about like current suicidal thoughts. So again, you can just Google ask suicide screening questions and get this as a resource for yourself. Most of you are probably not familiar with this. So this is a paper I published in the July 2016 issue of Contemporary Pediatrics. So this was primarily with pediatricians in mind, and came out because I, here at Children's and UT Southwestern in Dallas, since October of 2013, I have done monthly lectures, didactics with our pediatric residents that rotate through our adolescent and young adult clinic, and training them and how to assess and respond and do a risk assessment for an adolescent patient of theirs who engages in non-suicidal self-injury, because the residents don't get any training anywhere else, even in medical school, and even in fellowship if they do pursue a fellowship later on. So they're going to likely see, if we talk about 1 in 5 adolescents having engaged in non-suicidal self-injury at some point in their life, they're going to have many patients who self-injure. So I wanted to provide them with one, if they only had 5 minutes with a patient of theirs, or they could spend as much time as they want, but if they only had 5 minutes, 1, what are the questions to ask? 2, why ask these specific questions based in theory and research? And 3, how to ask these questions. So I'm giving them the words to use very specifically with rationale and how to do a risk assessment that's going to result in the most honest and open disclosure of one of their patients. At least that's the hope. And then I was thinking, how can I get them to remember these questions? So I created this acronym called SOARS, SOARS. I'll send a link for a PDF of this as well. You can just do it. It's free online too. There's a web-based version. If you just look up SOARS model and my last name, it should be able to pull up and the online version, and this is the PDF version. And the questions really start with a screening question. And this is also, even though I had pediatricians in mind and medical providers, nurses, this is also relevant for mental health clinicians. So don't think it's only for them. This is also for you, because I use it in my own work. And screening for non-suicidal self-injury, just as we know, screening and asking about suicide doesn't put the idea in their head if they're not already thinking about it. There are no iatrogenic effects. Asking about suicide, if anything, actually decreases risk for suicide, research shows. Same thing, asking about non-suicidal self-injury, it's not going to put the idea in their head. There are no iatrogenic effects. And the way I ask it is, have you ever hurt yourself on purpose without intending to end your life or attempt suicide? And I used to just stop there, but what we know is prevalence rates change depending on how we ask the question. And so if you just ask that question, we might miss a number of our clients that self-injure, adolescents or adults, because when people think about self-injury and hurting oneself without intending to end their life as in suicide, what do they think of? Cutting, right? So they may think that because they don't cut or haven't cut, then it doesn't apply to them. So prevalence rates are actually lower. But then if we give them examples, and so I now ask and follow up with my clients and say, like, and give them examples like cutting yourself, biting yourself, burning yourself, hitting yourself, severely scratching yourself, then we're actually getting more likely to capture these. And so this SOARS model is really a risk assessment, and where we're assessing different aspects of the behavior that, based in research and theory, but specifically research, increases risk for attempting suicide. So suicidal ideation, for instance, we know that suicide and non-suicidal self-injury are different. Some individuals may conceptualize them as on the same continuum, hence they might just say self-harm and include both suicide and non-suicidal self-injury. But I think phenomenologically, experientially, for these adolescents of ours, that are clients of ours, that could be dismissive of their experience, and they might fear that they're going to be treated as suicidal when they're not, or they might not feel like they're going to get enough treatment as if they were suicidal. So they might lie and say that they are suicidal if they're not. So being very articulate in this paper, I talk about how I ask these questions and why we ask these, because we know, like, for instance, self-injuring to avoid attempting suicide is actually the greatest risk factor of all reasons for self-injury, for suicide. And so I want to know that. I want to be able to differentiate, but also know that they can co-occur. And we know that NSSI is a robust risk factor for suicide attempts. The O is a 3-in-1: onset, frequency, and methods. And the theory here is the interpersonal theory of suicide, which I won't go into today, but a lot of you are already familiar with that. And like duration, onset, assessing duration, frequency, assessing number of episodes, and methods, number of different types of methods. A is for aftercare. Even though we're not medically trained, well, some of you might be, but I'm not. I'm going to ask questions on how they take care of the wounds afterward, because that gives me good information on how severe the behavior is in the client's eyes. Reasons, so the function, we do things for a reason, and we don't want to just tell someone to stop self-injuring or stop having suicidal thoughts. Like, well, when it comes to self-injury, what is it doing for you? Like, it sounds like this has been helpful. Validating and then exploring alternative strategies, because addition of alternative strategies is better than subtraction of existing strategies, like self-injury. And then stage of change. Not everyone who wants to change, or not everyone who self-injures wants to change. And so this is a screenshot of the pocket card in the paper. So if you want to implement this in your practice, this is not online. This is like an online resource or like using technology. I'm going to talk about that in just a moment, but something that's out there if you want to have a more streamlined and structured clinical interviewing when you're assessing risk for suicide among your clients or patients who self-injure. So let's finally talk a little bit about technology-based interventions for self-harm, and then we'll have some time for discussion, questions maybe, and hopefully I can answer some of them. But I'm not endorsing any of these, but some resources that are out there. I think all of you are familiar with the crisis text line. It's a global, not-for-profit like resource for people. I think young people, particularly, that are more comfortable texting how they feel and expressing, suicidal thoughts or non-suicidal thoughts and behaviors than they are talking about them. And so it's free, so that's a great resource. There's one that's based in the UK that I recently learned about that's specific to non-suicidal self-injury, but also self-harm. Hide Their Tav. It's a free resource. They actually provide free chats for individuals all throughout the world who may be struggling with self-injury, but they only do these chats from like Tuesday through Friday from 4 to 8 p.m. UK time. So they have like designated time for this. And they were telling me, so I learned about them because they found me based on a podcast I'll share with you as a resource here in a bit that I started and host. And apparently they are providing feedback in this, I guess, consultation, not necessarily therapy, but chat of like peer support anonymously. So they don't ask where the person is from. I guess they can find out, or sometimes the person just tells them, but they don't. I asked them, like, well, what about if they're actually saying they're thinking of suicide and have a plan? They don't know where they are, so they haven't encountered that problem. But anyway, it's anonymous nevertheless, and and I think they're, on average, they'll even talk for hours with the person if needed. And it's free. It's through Right Lines in the UK. And here are one specific to non-suicidal self-injury. This one's in Germany, STAR, Self-Injury Treatment, Assessment, and Recovery. They do some research with this. You can go to the website to see if they're active or not and reach out to them. You could refer, I think this is also for adults. Therapeutic evaluative conditioning. This is an app, a brief mobile app that Joe Franklin and others have found that the duration, at least during the duration of the use of the app, has been helpful in addressing non-suicidal thoughts. So in 3 separate randomized controlled trials with a reduction of non-suicidal self-injury specifically at least the duration of the use of the app, not necessarily long-term effects. And same thing with online daily diary as an intervention that found a decrease in frequency of non-suicidal self-injury during the intervention, although levels returned to baseline after completion. So these are like virtual online, but probably not something that you can use. So same thing with this emotion regulation individual therapy for adolescents. This actually is developed out of emotion regulation group therapy, which is for more adults who engage in non-suicidal self-injury. And this is an individual therapy with mobile components. And I'm really excited to see where they take this as an intervention for non-suicidal self-injury among adolescents, because I would love to implement this in my practice. And this one's in Sweden. But what can you refer? What can you use? And these, I mentioned at the beginning of this presentation, single session interventions. I think that's really what we're going to find the most use. So this is Jessica Schleiter at the schleiterlab.com, I think is, or .org is her website, and really focuses on just these single session interventions that individuals who may not want to pursue therapy or have time have these free resources that online that don't require a person, but just going through these modules at a self-pace that lasts about 30 minutes has shown promise. And this is just one of their projects. You can go to schleiterlab.org. I don't personally know her at this point, but they're doing great work. There are a lot of different interventions. And here, there are 3 steps that they talk about. So this is kind of like a development of their intervention. as well as the intervention. And so the first one is they have these individuals choose one of 3 different 30-minute web-based activities. So you have 3 listed there, and then they ask about their thoughts related to it, and then what advice they would give to others. So these are actual interventions, and then they're learning from those, using the interventions and implementing the changes and advice from those, the feedback from participants for the intervention. This one's specific to non-suicidal self-injury and suicidal thoughts. Project SAVE. So this and all these single session interventions use 4 primary elements for youth mental health in order to guide the development of these single session interventions for youth. They drew these components from basic research from social psychology and qualities common to self-administered single session interventions and brief interventions that have shown promising effects in the past. So here they looked at, well, here you have the 4 aspects. So brain science, so providing psychoeducation, and then empowering these youth to be in an expert role, helper role. And then the S stands for saying is believing, exercises to solidify the learning throughout the process, and then T for testimonials and evidence that they would get from others. So these interventions actually have advice that previous participants have given to those going through. So social psychology principles, if we borrow from that, suggest that we're more likely to accept advice from people that are similar to us and that have gone through similar things. And so that's kind of what they're pulling from. And so this study, you can find all about it on sciarchives.com and actually at the schleiderlab.org as well. But they looked at the likelihood, the single session intervention, 30 minutes, likelihood of future non-suicidal self-injury, 3-month frequency of non-suicidal self-injury, 3-month frequency of suicidal ideation, and then a desire to stop self-injuring as well as self-hatred. Unfortunately, the intervention didn't necessarily reduce long-term outcomes for self-injury, suicidal ideation, or self-hate relative to the control group that they were. But they did find that it temporarily reduced self-hate and increased the desire for them to at least stop self-injury. So if we talk about stages of change and not wanting to stop or thinking they can stop, going through this can actually decrease self-hatred and increase desire to stop. And if we think about self-hatred, which is a little bit different than self-criticism for non-suicidal self-injury, research has shown that those high in self-criticism are more willing to endure pain for longer periods of time and even experience improvements in their mood during pain. But then people with low self-criticism, actually their mood tends to improve after the removal of pain. So self-criticism and self-hatred, I think, is important here. In this intervention actually decreases the self-hatred, which hopefully would also decrease self-criticism and possibly improve the ability to stop self-injuring, to want to stop self-injuring, or actually not get as much reinforcement or positive reinforcement from self-injury. And then here's one technology-based intervention that's out of Florida International University. That's just about parenting children on technology use in general and screen time, that has shown some good positive results. I put the link here at the bottom if you want to look more into that. And I think it really empowers parents as well. So it's just kind of a strategy. One thing that I talk a lot about when it comes to technology and media use and smartphones, when it comes to parents and children, adolescents, is making sure when they introduce technology into the home, like a smartphone or a video game, or most often smartphones at this point, like parents trying to figure out what age is the right age to give their smartphone. A lot of parents don't think about this in advance. So it's kind of like when I'm providing consultation with parents, it's a little bit after the fact, but differentiating this smartphone as either a right, a privilege, or a gift. If having the smartphone is a right, then we can't necessarily take it, then they should have it, right? Most of us don't agree that having a smartphone is a right. It's either a privilege or a gift. The tricky thing is a lot of parents give these smartphones without any attachments to it. It's a gift. Well, you can't take a gift back, right? Because otherwise it's not a gift. So couching it in terms of a privilege. So maybe the smartphone itself is a gift, but the data that it uses is the privilege. And so you might be able to, they can keep the actual phone if there are any problems that they're having, and the consequence could be loss of privilege to the data that that phone would use. And that's a lot of back and forth with the phone company, but helping parents understand that and better using that, and as well as with screen time, I think is helpful. And as we come to an end here, this is the podcast I was mentioning. I launched it on January 1st. So I chair the Media and Communications Committee for the International Society for the Study of Self-Injury. So I have access to the leading experts, many of whom I've cited in this presentation, and who've already contributed to the podcast. So it's meant to be a resource for parents, professionals like you and me, as well as people with lived experience of self-injury. So it's on all major podcast platforms, and you can use this as a resource to share with any of the parents, or a lot of the listeners are actually adolescents. They're teenagers listening that have lived experience of non-suicidal self-injury. And so we focus more on that than on suicidal thoughts and behaviors in here. But some of the episodes, we do differentiate more clearly at what risk factors are present among non-suicidal self-injury that would lead to suicide attempts. So so there's some great episodes out there. I encourage you to share it with families that you treat that are not sure how to manage like their kids who self-injure, or that are adults in self-injury. And here are some resources that you can find on your own or read. So these are specific to non-suicidal self-injury. Again, you'll be able to see this later. And these are some of my favorite resources and websites. And you can reach me here. And let's see. Oh, you can also follow the International Society for the Study of Self-Injury and join if you'd like. It's a nominal fee, and it's like the leading experts. It's really great organization. Thank you.
Thank you so much, Dr. Westers, and for everyone for attending and submitting your questions. So we have a few minutes for Q&A. We've received quite a handful of questions throughout, so let's get started. So first, I think a pretty timely question is, have you looked into the correlation between screen time, suicide ideation, and non-suicidal self-injury during the pandemic, or has COVID affected your work with adolescents? And have you seen self-harm or non-suicidal self-injury increase locally as a result?
Yeah, that's a great question with the pandemic. And I think the challenge is, because of the pandemic, most people have been on their screens, have been using screens more often, whether to, again, it's like, how is it being used? Is it to connect with friends, or is it to just passively scroll, doom scroll, that they'll call it, which is problematic. But as far as research looking at screen time specifically related to suicide and non-suicidal self-injury during the pandemic, I don't think there is. But we do know that there's been an increase in suicidal thoughts and behaviors and non-suicidal self-injury during the course of the pandemic. The research does show that. But suicide deaths, we don't know the data on that. There was not an increase, at least in 2020 of last year, there was not an increase in actual deaths among children and adolescents in 2020 versus any other year, or 2019, that is. So but then we're still here, we are near, second year into this, but we don't know that how 2021 is gonna pan out.
Great, thank you. This is going back to the anecdote you gave of your client when you were younger in school. Could you briefly explain the safety contract again? We had a few people wanting to get that clarified. That's what it entailed.
Yeah, safety contract, I don't think anyone uses it anymore. So that was this idea that if you could get someone to like sign and commit and contract that they won't kill themselves, then that would motivate them to not attempt suicide. But then that would give people clinicians a false sense of security that, well, they could back it up in court. It's like, well, research doesn't support the use of that they're even effective. So I think a lot of clinicians back then and before had this false sense of security that it would hold up in court, that they would use it as a defense, but it's just this false sense of security. And so the suicide contract was specifically about, I will not kill myself. And then in this case, it was, I will not self-injure or cut. And then that just, when she did, that nullified the entire contract. But safety planning now, it's the preferred term, where we just explore what can you do to cope with these thoughts. And then we still sign it. I have a copy. I can send a copy of maybe a sample of a safety plan. You can just find one online. It's really a glorified document of healthy coping strategies for when someone has suicidal thoughts.
Great, thanks for the clarification. And there's questions on self-harming that doesn't include suicidal ideation. So could you speak to that a little bit? Someone is saying they understand that asking about suicide won't make a person or adolescent suicidal. However, they find that asking and providing examples provides a lot of false positive reports, such as if you ask, have you ever cut or engaged in self-harm, such as burning? And then the child or adolescent says yes, but then they have no intention of suicide. Maybe they're just playing with a knife or the curling iron. Do you have any thoughts on determining the difference?
Yeah, so intent is the primary difference between like suicide or non-suicidal self-injury. So asking about like if someone accidentally hurts themselves, that's not intentional. And so when we talk about non-suicidal self-injury, we mean someone intentionally harming themselves to cause immediate tissue damage that's not socially sanctioned within our culture, and it's not for display. So it's not tattooing. So if someone accidentally burns themselves with a curling iron, then we don't call that non-suicidal self-injury. We just call that an accident or burn. On the other hand, if they use a curling iron to intentionally harm themselves non-suicidally, then we would consider that an act of non-suicidal self-injury, but not necessarily a suicide attempt. So a suicide attempt and non-suicidal self-injury are separate. And there's always some sort of intent to die or to end emotional suffering when someone attempts suicide, regardless of severity. Non-suicidal self-injury, there's always an intent to cause immediate tissue damage, but without any suicidal intent. So hopefully that helps.
Yeah, I think it does. Thank you. A few questions on how are there healthy ways to limit time on devices without the battle, I would assume, between parent and child?
Yeah, that's an age-old question that, it will be an age-old question, I guess. It's still so new. I think for me, when I'm having these conversations, when it comes to like smartphone, cell phone use technology, I like to have those conversations with both the parent and the teenager in the room, where I will always say, I think and I say this in front of the teenager, I think it's always fair to have like a time for us to put up our phones at night. But then again, the parent has to model it, because the worst thing we can have is a parent that says, do as I say, not as I do. And then they're on their phone all the time. And actually, we know research shows that those parents who are on their phone a lot, greater amounts of time, their children are also on technology on their phones a greater amount of time. And so we'll talk about, having I don't want to call it a curfew necessarily, but like cell phone use just disrupts sleep. And we know sleep is a risk, like inadequate sleep, poor sleep is a significant risk factor for both non-suicidal self-injury and suicidal thoughts and behaviors. And a lot of kids nowadays are, they're staying up on, I have too many kids right now that I see that are staying up on FaceTime with their boyfriend, girlfriend until they fall asleep. So they're on their hours, but then if someone makes a noise or someone needs help, then they like wake up and this is self-fulfilling, cycle, or the cycle of inadequate sleep and greater distress emotionally. So I think it's fair to put up phones and have non-electronic zones like dinner time, homework time. And so there are some sample contracts that you can use as far as agreements with smartphone use, and not many kids like that. Some of the terminology you can find a lot free online. I think I've used one and developed it with a parent and a teenager who just really struggled and was with their use of the smartphone and getting into doing some troubled behaviors as a result. But it's tricky. Yeah.
Great, thank you. That is all the time we have for questions. If you wouldn't mind going to the next slide to review our upcoming events, Dr. Westers. Great, thank you, everyone. You can go to registration.nytech.org. We have adding high value through trauma-informed care and evidence-informed paradigm shift part 2 coming up next week, and then combating social isolation with youth and families. And that announcement will be going out very soon. We have Dr. Wester's contact information in these slides, and the recording and slides will be up on ctachny.org within just 2-3 days. You can review all of the really great resources that he mentioned throughout this presentation. And Connor, the host, put in the feedback survey in the chat, and I believe it will also open up as you close out of the webinar. So if you could really please take a quick second and fill that out for us, let us know what you thought and what you'd like to see from us next. We really take your feedback into consideration. So thank you so much, Dr. Westers, for your time. This was really engaging, and I think everyone learned a lot. So thank you everyone for attending, and have a great rest of your day.
Thank you.